So thank you everybody for coming along today. It's great that you've come to our first PPIE webinar from the Rare Disease Research UK platform. So we're excited to get this going. We have a really good lineup of speakers for you today, and they're going to be looking at 4 quite different angles in terms of PPIE, but I think they're all equally important to consider if you're starting to look at establishing your own PPIE initiatives. We're going to have approximately 20-minute talk from each of those speakers, and there'll be time for a few questions at the end of each speaker. If questions occur to you while they're speaking, feel free to put your questions in the chat. Anna and I will keep an eye on those, and hopefully we'll get to them for you. I'm also going to try and have a short comfort break after the second speaker, because we do have a longish session today. So that'll be at around just before 11 o'clock probably. So I am going to just share my slides. Just bear with me one moment. Has that become full screen for everybody? And if you could put your thumbs up, I can see you.
Yeah, I can see it fine, Amy.
Great, okay. So this is the lineup of speakers we have today. We're going to begin with Sadia, who's an experienced contributor to PPI initiatives in research. Sadia, I'll hand over to you. I am going to run your slides for you though, so do go ahead.
Thank you, Amy. If you can go on to the first slide, please.
Yes, it's not liking. Slide down. That's very nice. There we go.
Yeah. So I'll just be sharing my perspective of a PPI contributor. Next slide, please. So this is a little background story of who I am. I lost my daughter in 2010 to suspected ARPKD, which stands for autosomal recessive polycystic kidney disease. I do have 4 healthy boys. When I lost my daughter, I knew exactly what the condition was as soon as the sonographer told me at the 20-week scan that there was no amniotic fluid. And the reason that I knew what this was because my sister had by then, I think, lost 3 babies to ARPKD. So I had some understanding of the disease. I'm married to a first cousin on my mum's side of the family. My sister is married to a first cousin on my dad's side of the family, and my parents are actually first cousins. So this is after my loss, we kind of understood a little bit, or actually took seriously genetics. We had the whole family tested. Both my parents actually carry the faulty ARPKD gene. They do have 7 healthy children, which is considered lucky because there's usually a 1 in 4 chance of having a baby that's affected by the condition. But then are they lucky because they've gone on to lose grandchildren to this condition? It's a bit of a strange one in my family because I've just re-entered genetic services again because in my daughter's DNA, they couldn't find the faulty gene, nor could they find it in my husband's DNA, but they suspected that it was ARPKD because of the family history. So we are currently having whole genome sequencing done and hoping that that'll give us some answers, but it may not, but then it might also throw some other things out there that we're not expecting. But it would be good to have some kind of I guess further exploration of what this could have been. My sister lost 5 babies in total, so 3 that were full term, and then 2 she terminated after a CVS test. And just generally, when you talk about this, like, you're married to a cousin, you've lost babies, there's a huge stigma around this topic, just generally within the community, as well as just generally within society. So you kind of feel quite stigmatized by this. People are very judgmental. They don't really understand. And especially in my community, people are quite fearful of you because you have all this bad luck, and then they kind of worried that that bad luck is transferable. So we do openly talk about this, but you do get that feeling that people don't trust you and people are fearful of you, and they're really quick to judge you. Next slide, please. Just waiting for that to change. It's not changed on mine yet. The next slide was going to be about the stigma attached. Yeah, no, it's okay. I'll just carry on talking. The next slide was going to be about the stigma around these topics. I did a quick Google search of consanguinity, which means marrying your first cousin, and all the articles that came up, they're quite negative. It's partly to do with the media, how they portray the subject as well. There's a lot of negative attention on the topic. It's a lot of stigma and taboo, and you're blamed for your loss. Some of the quotes that I remember reading were that you're a drain on the NHS. And then there was another Twitter screenshot of some discussions on Twitter, always talking about banning the practice. So even to share your story, for example, it's really difficult to do that when there's such a stigma attached to this topic and things around it. So you kind of lose trust, and then you reflect on your experiences just generally in healthcare. When you go to book in for a pregnancy, the first thing they will ask you is, are you married to your cousin? And it's after you've experienced a loss. I had 3 healthy babies after my loss, and each pregnancy is like people are judging you, even in healthcare, of why are you pregnant again, after you've suffered a loss and there's this possible condition in your family. So it's really hard to build that trust with healthcare and just generally just talking about these topics. And I got involved in PPIE around experiencing this kind of stigma. There was a release of the Infant Mortality Scrutiny Inquiry report by Birmingham City Council in April 2021. And this highlighted the high infant mortality in Birmingham, which was due to the Pakistani community and the practice of consanguinity. And when I read this report, I actually felt attacked by this report. And I felt like I needed to have a say because there was no patient voice on that report. And for me, as a patient, to believe in any kind of recommendations, I need to know that patients have been involved in that report, that their views have been taken into account. So I contacted the council. It was the public health department, and I contacted someone called Dr. Marion Gibbon, and I selected her just because I thought she'd be a nice lady. I thought Marion was a nice name. And she replied to me within 20 minutes. She asked me to join the infant mortality task force as a patient voice, and that was a life-changing moment for me because I felt I'm finally heard, and now I can kind of help make some kind of changes. And something that I always hear about is turning your pain into purpose. So I got involved with the Infant Mortality Task Force, and from there came many opportunities to become a PPI member with different projects and groups. And I really felt I was doing something positive rather than always, feeling like there's always this negative aspect to it. Now it turned into doing something positive. And for me, it's been absolutely life-changing, the opportunities that I've had. My area focuses on maternity safety, women's health, genetic services. I had the opportunity to go to South Africa to set up a global framework on PPIE in women's health. Joined the Baby Lifeline group, and the focus around maternity safety and feeding into the genetic services. And it's been life-changing because I then had the opportunity to study for a PhD. And this, I feel like I was so lucky to get onto a PhD. I just finished my bachelor's degree, and that was in early childhood, so nothing to do with health. And I went straight from that to a PhD. And I think that was based on the experience that I'd gained in research as a PPIE contributor. I also undertook some community research training and became a community researcher. And I feel like the skills that I built up really helped me to get onto a PhD. So now I am in my second year at the University of Leicester, and my research is focusing on Muslim parents' experiences of ending their pregnancies when there's a problem with their baby's development. And that interest comes from my sister's experiences of having the 2 CVS tests and 2 terminations. I have supported other women who've gone for terminations and who've told people that it's a miscarriage because of the taboo and the stigma around the topic and the lack of understanding. And it makes me wonder, how do we know that the services are meeting the needs of these parents when they don't share? No, there's a gap in research. We don't know what the experiences are. So that's why I hope to do with my research. And it's made me realize that exactly how powerful being heard was for me. And it made me realize my potential. Next slide, please. And I think PPIE has been powerful because it gave me that opportunity to do something positive and to use my voice. And I want to give those opportunities to others. So what I've done with some of the groups I'm involved in is recruit new PPIE members. And this is not as easy to do. With some people, I've had conversations for over a year with them before they've built up that courage and finally, attended a meeting. It takes a lot of courage and a lot of understanding of the barriers that people have to get involved. I was like that right at the beginning. I remember when I had the first email asking me to express interest, and the amount of times I changed the wording of the email because I thought, this is an academic. The last thing I want is there to be any like spelling or grammar errors in the email. And some of the things that they did for me, such as meetings not being held at the university, meetings being held locally to where I was. So not me going out to them coming out to me, which I felt was removed, was really helpful because it removed a lot of barriers such as childcare, being close to home, traveling, and things like that. So it's about understanding the barriers that people have to enable them to take part in PPIE. And some of the work that I've been involved in, such as, you're right, lay summaries, but also communication with PPIE needs to be lay as well. And, a lot of researchers do tend to get very technical. And I remember with technology as well, the first meeting that I had to attend with on Teams, it was so difficult to get online, and someone actually supported me. We did a practice meeting beforehand, and that really built your confidence. There's things like reimbursement. I know that I've recently set up a group, and I was adamant that PPIE has to be reimbursed according to the national standards. But it's amazing how the first thing to get cut off is the PPIE costs. When people are thinking about the budget, but I was firm that no, we have to actually stick to the guidelines. I can't promote PPI and then not stick to the standards. Simple things. What good PPI should look like, such as a facilitator, knowing who the person is that you should be contacting. Another thing that I've recently kind of thought about is safeguarding. There's no ethics involved in PPIE, and sometimes some of the things that you talk about can be quite sensitive, and I worry about those contributors. Is there any support for them? Are they being signposted anywhere? Because we're hearing about their experiences, they're hearing about other people's experiences, and we still need to ensure that they're safeguarded. Some of the things when you've been involved in PPI for a long time is you are always relied upon to support, and it's okay to say no sometimes. So I think that's an important thing about reviewing your own capacity. And I think you want to get something out of PPIE. Not everyone does, but I know a lot of people do. So training is really important, whether that's training to get onto meetings, technology, or research skills, but also transferable skills that people can use onto their CV, put it onto their CV to help them get a job. I recently took part in a group, and there was opportunity to do some qualitative coding, which I as a, I'm doing a PhD, so obviously that was going to be interesting for me. But people did get onto that, and it was really interesting, holding a focus group discussion. So really understanding deeper of what's actually involved in research. And I think it's really important to create these opportunities. They might not suit everyone, but I think it's important to have these opportunities and really listen to PPI contributors, listen to people's stories, understand the barriers they face, and then try to remove some of those barriers to make it a little bit easier for them to attend meetings. And as I mentioned before, I support in recruiting new members for some of the groups that I'm involved in. And I think that comes from understanding that I'm now in a position of privilege. So I need to make sure that I'm supporting these voices that are unheard and underserved in research, and supporting to ensure that their stories are heard and their voices are heard, and that they can also take part in PPIE. Because I always think, and this is the last line of this slide, I always think, if I'm one voice being heard and it was so powerful for me, can you imagine like the outcome when many voices are heard? So that's kind of what drives me to continue doing this. Next slide, please. I think that's the last slide. Next slide. Yeah, it's just this quote which I really love, and this reminds me of how I felt right at the beginning when my story, it was just a statistic, when people weren't listening to those stories behind those statistics, and how important it is to do that, but also how powerful it is for that person. And I think that's what we get involved in PPIE to do, to share our experiences. And I think those stories are either an ongoing experience. I think an ongoing experience is what turns into a story. And I think hearing stories is really, really important and really powerful. And I think I'll end on that slide. And thank you all for listening to me today.
Thanks so much, Sadia. That was a really interesting presentation. It's really powerful to hear what you say about stories being heard, but also everything you were saying in terms of advice to researchers to make PPIE work. Do we have any questions for Sadia? While people are thinking, I'm going to take chair's privilege and ask a couple. I was really oh, sorry, no, let's go to Rihanna. Seeing you've put your hand up. You go first, Rihanna.
Hi, sorry, I'm also struggling with a cat at the moment. Thank you, Sadia. That was a really fascinating presentation. I actually was lucky enough to hear you speak at the MDS Research Festival recently as well in Birmingham. Very inspiring story, and I think the journey that you've taken is incredible. My question really is, I know that you're one person and you will have different barriers to involvement to the next person, but I'm wondering, in your experience and dealing with, other PPIE representatives, what do you think is the greatest barrier to people getting involved in research?
I think it's having that time to attend meetings. Usually it's just that one meeting and that one time, either in the morning or the afternoon, which makes it really difficult because some people are working, some people have childcare commitments. And what I think has really worked is with one of the groups is they gave an option for 2 different times. So it was one day, you can have the morning or you can have the afternoon. And actually they did 2 or 3 days in that week, so people could choose which one was more convenient for them. It's a lot to do for a researcher to put on a couple of meetings and for people to attend, but it was actually quite powerful. It worked because a lot more people did attend. So I think that often it's the time to attend the meeting.
And do you think that's higher in the priorities than funding, even having that flexibility?
I think so. It's kind of like a double thing. You need that funding to have that flexibility.
Yeah.
But it's definitely on one of the top things. Definitely, yeah.
Thank you. That's great. Thank you.
Any other questions for Sadia? So I think you're giving some really good sort of very practical tips that people can respond to. Such what you found really useful was an academic coming to you, at least initially, and having a practice meeting, and all of those kind of things mean that it's much more welcoming for PPI contributors, especially if you're getting involved for the first time. So all of that's really useful. We're going to talk a little bit later on in terms of the impact that kind of, it's quite resource intensive. So we'll be talking a bit later about how researchers might sort of balance these doing these different things. I was interested in the thoughts that you started having around safeguarding and the ethics process. I just wondered if you could expand a little bit on that, on your experience and what you're thinking about that.
I think it was more to do with I've just had my ethics approved for my interview study, and what thank you, and the process that you have to go into, and there's a lot of thought put into safeguarding your participants, and we forget that PPI contributors have that experience, that lived experience, but safeguarding isn't really thought about. You can just, arrange a meeting and people will attend. You don't need to go through ethics, but it's the same issues that are being discussed as, would be in a focus group or a, interview study. And, a lot of the times when I've had discussion with researchers, it's like they bypass the ethics. I know good practice, there are a lot that will have the good practice, will signpost, but it's not a requirement. And it just made me reflect on that there's not really safeguarding is not really built into PPIE. Yeah.
Yeah, that's a really interesting point, Sadia. Thank you. That's a really useful thing that I'm going to take forward and discuss with colleagues working with me on PPIE practice. David, go ahead.
Thanks very much. And Sadia, really powerful presentation. I really enjoyed listening to that and learned a lot from it as well. I have a question about diversity in PPI, if I may. I'm a researcher, I do PPI, and one thing that we're obviously aware of as a community is the relative lack of diverse viewpoints in PPIE. And obviously, to state the obvious, you come from a minority ethnic background, and I think it's really interesting to see, to hear your experience, your lived experience of being judged for things like first cousin marriage, for instance. I wonder if we're thinking about diverse PPIE, do you think that is there a requirement that we have, for instance, a minority ethnic group or group? Is it better to have it as a group of people sharing the same characteristics or ethnicity rather than within minority ethnic group people within a broader PPI group, including perhaps more educated white people? Do you have any experience of that you could share with us? I'm just conscious that feeling of being judged might be just the same in a PPI workshop where you are one of many, and it's still in a minority, if that makes sense. I'm not explaining it very well, but do you understand what I'm driving at?
I think I do understand. For me, some of the safest places have been where there's a lot of different ethnic minority people involved in the group, rather than one that was just for example, for the Pakistani community. And I guess it has to do with the topic that you're discussing. And I think from the experiences that I've had, you do feel like you're on the edge of community. I always say I don't feel like I actually belong in that community. You're on the edge of community because of the experience, the lived experience that you have. So if I was going to discuss baby loss, pregnancy loss, and things like that, I'd probably feel safer in a group that was of many different ethnicities, because I feel like they're less judgmental. And that's my view of my community. And this is similar for example, with healthcare practitioners, for example. I would feel more comfortable talking to someone who wasn't from my background because I feel like they won't be as judgmental, which is really strange when you think about it, because it's all about having people that look like you, that are from your background in the services to make you feel comfortable. But it doesn't suit everyone. It may work for some people, but when you're talking about really taboo topics, I think openness is probably better.
Thanks very much. It's incredibly useful. Thank you.
Thank you.
Really insightful. Thanks, Sadia. Jennifer Kettle.
Hi, Sadia. Thank you. That's been really helpful. The practical list. I was just wondering, in terms of when you've been to meetings and sort of group discussion, I just wonder if you could share anything you found either particularly helpful or particularly unhelpful in terms of how those have been facilitated.
helpful is really having a wonderful facilitator. So some of the groups that I've been involved in, the facilitator is just absolutely amazing. And they really make you feel comfortable. And the way the session is run really works well. Sometimes it's not been as good. So there's always like, negative experiences and good experiences. Something that's really, I find worked really well is being sent meeting minutes in the post. And it sounds like a strange thing, but actually having a physical copy of the meeting minutes and, looking through, oh, this is what I said, this is my, involvement, is actually having something physical of that represents your involvement. That worked really well. I found that really showed the value of my involvement. It's expensive to print out and just being sent like a printout of 6 meetings was really nice. So that worked really well. And yeah, it's just kind of like, it depends on the meeting really, how meetings are run. It just depends on the experience of the facilitator. You need a really good understanding facilitator, and I think in meetings when I've had that, they've just been amazing, and you feel comfortable, and you're willing to talk about things more openly. Thank you.
Thanks, Sadia, and thanks for your question, Jennifer. And I think there are things that facilitators can do kind of around the meeting, aren't there, as well? So make sure everyone is sort of onboarded, to use a horrible word, before the first meeting. Have individual chats with people to make sure you're aware of any issues, any concerns, and then also to offer one-to-one chats after meetings, especially if you're talking about anything particularly sensitive. There may be thoughts that occurred to contributors during a meeting that they didn't feel able to share for whatever reason, but a one-to-one chat afterwards can often capture those thoughts. Tony, go ahead.
Hi, thank you, Sadia. That was great. Although it's a slightly different context, and I'm aware of this from our work on the genomic side, and your valuable input into it. One of the issues you mentioned when you were trying to get across to communities, because of course PPI reps are hopefully representing wider groups, and one of the troubles is, whilst everything in the NHS has a PPI group, whether we really get into these communities is an issue I've been grappling with for a while. And I remember your story of when you went into a school to talk to pupils and colleagues of your ethnicity, and a mixture of them as well, rather than you being fronted up straight away, right, we're now going to have a talk from Sadia. It was part of another conversation with the ladies about ladies' problems, sort of stuff, and then you just were gently entered into it. And it was a very good example, I think, and a bit reflected of what you've just been talking about and what Amy mentioned, of if you need to, if you're trying to introduce a tricky subject, then maybe not having it listed down there as a header, right, we're going to do this, but it then is drawn into the conversation in a more subtle way. And the second part, which I may have missed, I apologize, talking about whether you really feel valued and whether your views have been taken note of, because I know from what you've explained to us before, there's been occasions when you've been part of the system, but actually it's relatively lip service, and that's very frustrating. So it's and we've certainly learned a lesson for the benefit of everybody else listening in, we being the Central South Genomic Medicine Service Alliance. So I chair a PPI group there, and Sadia is one of our great members of that. And we've learned from the Southeast, I think it's group, where they had a charter put down for what you need to do for your PPI groups. And it reflected what you've just said, Amy, there, of ensuring that you're engaging right at the start, not sort of, literally when you're sorting out an agenda for a meeting, you've actually asked the PPI members first, right, this is what we're going to start off with. What do you think? This is how we're going to do it. So, this sort of co-production, this great word that's trotted out, often isn't necessarily co-production. It's people following, a sort of process. So I don't know, if you want to elaborate on those two issues, Sadia.
Yeah, I can. So there's like this bottom down up, so bottom down, top down or bottom up research, and I find that actually researchers that are working on their own are probably doing better PPIE than those right at the top you know, who are embedded within the organizations. So I have had some input which has felt really tokenistic. I was involved with some of the work with the NHS, and I was on the Health Innovation Network on the evaluation arm of things, and then it was just dropped, and you're not given any reason why this has been cancelled, and you're just, you know, fobbed off from one person to the other, and it feels really like, you know, you're not valued, and it's a horrible situation to be in, because you just never get the answers. So that's like a big organization, you know, top down. But researchers, you know, will do more to really help you be involved, and, you know, they will follow up, and you'll have a debrief, and I feel like it means more. It's more, you know, it's just, you feel more respected. So yeah, that's what I would say. And then the first point that you mentioned about communities, so the work that we were involved in was talking about in my story, for example, and the risks of first cousin marriage, and it was kind of within this package of best start in life. How do you give, you know, you're not thinking about pregnancy then at that time in school, but you will reflect upon this later in life. And it was called something like the best start in life. You know, things like contraception and healthy pregnancies, and we were kind of tucked into there. And it felt like it was a good idea, a safe space. Like, you know, it's not a standalone session, which is more shocking. It's kind of built into something, really embedded into something. So that worked really well. And then the last point I just wanted to touch on was about communities. I feel like there's a lot of work that needs doing, because if you're an experienced PPIE member, you kind of represent a community, and people will just go to you rather than other views, because it takes a lot of work to set up that workshop, to recruit new members. So people do rely on existing PPI contributors or existing community groups, and they're not always the best place, because those people that don't access these services, you're still not getting to them because they don't access the services. So it's better, I say, to go in and, you know, hold your workshop in a school or a nursery where parents attend. You know, there's coffee mornings that take place in schools and nurseries. Use those and recruit new members rather than always relying on existing ones, because we need a variety of views. So I, you know, and again, it's a lot of work for the researcher to do. And this comes, you know, this is where PPIE and funding kind of comes into it. It's not just like one thing that's just added on and you need to tick a box. There's a lot of work that goes into PPIE, as similar like with your ethics applications, a lot of work and a lot of time. And I think you know, that amount of time and commitment needs to be put into PPIE as well.
Thanks, Sadia. We've got time for one last quick question. Louise, your hand is up.
Yeah, I will be quick because I know time's pressing. It was just whether you've had any pushback from people that you're now so expert and you're doing a PhD that you can't be a PPI person anymore. I have a friend who was told by the NHR that because she was doing a PhD, she couldn't be a PPI representative. And as she said, doing a PhD isn't going to cure my diabetes.
Yeah, I haven't actually had pushback yet, but it does make me reflect on why are they still relying on me, but they need to get other voices. And I think I haven't had pushback because I represent a very kind of an area that's just unheard of. There's not people that are talking about this. I'm probably the only one out there. So that's why I've not had the pushback. But I always reflect on this two hats that I wear, the PPI hat and the PhD. And they, you know, they're so on each end of the scale, but are they? And actually, I feel more powerful as a PPI person than a researcher, because I feel like I don't have to justify anything I say. My experience is taken at face value. As a researcher, I have to justify everything that I say and believe. So I feel like I have more power in PPIE.
Interesting. Thank you.
Thanks, Sadia. That was a really interesting and yeah, interesting debate point to end on. That's fantastic. Thanks so much. We're going to move on now to our next speaker, who is a non-clinical researcher from Oxford, and that is David Church. David, I'll hand over to you. And hopefully you won't need me to share your slides, because obviously that didn't go well last time. Perfect. Yeah.
Everything moves around. Great. Yeah, so I'm no longer on mute, am I? You can hear me and you can see my slides, I hope. So yeah, thanks very much, Amy. And we really appreciate the invitation to speak about this. I should qualify this because I am a clinician, actually. So I'm going to talk about kind of basic research, but it's a little bit applied really. So I hope you forgive me that transgression and don't bar me from future events. And hopefully this will follow on quite nicely from Sadia's presentation earlier, which was incredibly powerful and really, really helpful actually. So there are many common themes, and I should just qualify what I'm about to say with the statement that this is a personal opinion. This is not revealed truth or established fact, so it is personal opinion. I'd be very happy to debate things in the questions afterwards. So I've been tasked with talking about researcher perspective and challenges and benefits of PPIE from a basic science perspective, but as I say, it's going to be a little bit translational, so please forgive me that. My personal experience, I'm a medical oncologist. I see patients with bowel cancer in the clinic every week, but I mostly do research. I've been a clinician scientist for the last 10 years. Before that, a clinical academic trainee. I've been funded by the Academy of Medical Sciences and latterly Cancer Research UK, and I've been active in PPIE really for the last 7-8 years. I think since 2017 I worked out, looking back, initially with my work with Genomics England. So I lead the endometrial cancer GSIP, so the research on endometrial cancers that we've captured from Genomics England, and also the colorectal cancers as well, and also doing a very substantial PPIE as part of a project that I lead, which we're calling LynchVac. So this is to work up a vaccine to prevent cancer in people with Lynch syndrome, which is the commonest cancer predisposition syndrome in the UK and globally, I think I'm right in saying. So as part of that, I've done regular talks, so talks both to fundraisers, so individuals, the general public fundraisers, as in fund runs and things like that, particularly for Cancer Research UK, and the lay public at engagement events, and also talks to researchers like people on this webinar about the benefits of PPIE, and hopefully I'll convince you of that over the next few minutes. So just to summarize or break down the benefits of PPIE as I see them, I think we can have 4 main headings, and again, happy to debate these. Priority setting, understanding diverse viewpoints, which we just heard really powerfully from Sadia actually. Always learn new things that you didn't really realize before, of course, when you hear diverse viewpoints. Communicating your science, I think, is a real benefit of PPIE, and maximizing your impact, which is why we all do research, of course. So to first focus on priority setting. So priority setting PPIE it varies massively in scope. So this could range from simple surveys, Microsoft Forms, or SurveyMonkey type thing, through to really detailed in-depth exercises. So for clinical research, that would be things like the James Lind Alliance, which many of you will be familiar with in terms of priority setting. And I think one thing that I've learned is that identifying unmet needs in research might not be what you expect as a researcher. So, when you go out and sample the opinion of the people that you're seeking to help, you might find that what they think is their unmet needs are not what you thought before, actually. So it's really valuable experience. One exercise that I can speak evidence for is some work that we're doing in terms of people with cancer. There's an overarching drive from funders and researchers, not just to treat cancer better, but to prevent cancer, for obvious reasons. And although people with cancer recognise that's a very important endeavour, one of the things that came out of a recent priority setting exercise that we did here in Oxford was that people with cancer don't want to be forgotten about, that they still want us to research treatment for cancer and better management for people with cancer. It's all very well preventing cancer in the future, but we mustn't forget about the people that are suffering with the disease at the moment. So that was something that maybe we could lose sight of, because when the trend is all in one direction, you can kind of forget there are other viewpoints that need to be captured. And I think one area that I've learned is it can highlight areas where better communication may be particularly important, and that's really germane to the work that we're doing on vaccination, which I'll speak to in just a moment, actually, in a bit more detail. Of course, it could influence what you research. Many of us are wedded to our research priorities because we find them interesting and motivating, but you might find an aspect of your work that you perhaps haven't prioritised before that might be more relevant to those you're seeking to help. And I think, being perhaps deeply cynical, but not really actually, is that if you're going to have an argument to evidence why your research is important and why it should be funded, it's pretty powerful, saying that it's been highlighted by a PPIE exercise as being an unmet need. That's very difficult for organisations and reviewers to disagree with. Of course, they can't. So understanding diverse viewpoints, we've just heard far more powerfully from Sadia about that than I could ever convey. But I think from my perspective, our perception of public priorities and public understanding of science as researchers is often that of our peer group. And as researchers, our peer group typically is an affluent, educated demographic, often majority white, I suppose. And capturing other viewpoints helps ensure your research delivers its maximum benefits. So it's all very well having research that will benefit a subgroup of individuals in the fullness of time, but it needs to benefit everyone if it's going to maximise that benefit. And it can identify areas where better communication is required. So I think one thing that came across really powerfully from Sadia's presentation is the stigma associated with, for instance, cousin marriage, where we would reflect, that would cause any researcher to reflect really critically on that and improve their ability to communicate that and discuss those kind of issues in the future. So communicating your science, I think this is a real benefit, and it comes back to the principle of teaching, doesn't it? If you really want to understand something, you have to be able to teach it, explain it to somebody that doesn't have that same knowledge that you do. Actually, that really, when you can do that, then you can really understand something properly. So communicating to a lay audience really makes you focus on your science and think about it very critically. And if you do that carefully and give it the time and attention it deserves, it will really benefit you. So what is it that you're doing? Why is it important? And what will you deliver if your research is successful? And part of this is the kind of glib elevator pitch that we're all tasked with doing. So how would you explain your science in 2-minute ride in the lift with the CEO of the funder you're seeking to get funding from? But if you can do that, then so you can do it to the non-scientific public and actually even non-expert scientists, actually. So it really helps to have that exercise and think about those, write them down, refine them, and then you'll really be able to explain your science better, both in PPIE and generally, actually. So crystallising the key points you want to get across is really important. And one thing that I've learned doing PPIE over the last 7-8 years is that it's not just in communicating with the public that this helps, but it's also communicating with peers. So remember, the reviewers of your grants may not be experts, or likely not experts in your field. Actually, they will be scientifically educated, but they won't know the exact problem that you're working on, because nobody knows the exact problem you're working on better than you do, of course. I don't know how many of us are familiar with the curse of knowledge, but this is really powerful and helpful concept, actually, that when we know a lot, when we're specialists in our field of research, we forget that we didn't originally know that, and we forget that others do not possess the knowledge that we do. And so stepping back and doing PPIE, what is it I'm doing? Why is it important? What message do I want to convey? It really helps you step out of that curse of knowledge and think about how you're going to communicate that. And that makes you a better communicator and a better scientist, I firmly believe. And then maximising impact. So disseminating your, but why do we do research? We do research to have impact, to improve our understanding of science and to deliver, if it's life sciences research, to deliver health improvements for people. And maximising those benefits is much more effective, it's much more efficient with PPIE. So I think that take homes that I've learned and that actually Sadia highlighted really nicely in the previous talk, so I'm kind of just repeating things that you said, Sadia, is With PPIE, you can really use concrete over abstract examples. So in research, we kind of learn to speak in abstract terms about what we're doing, but actually in terms of impact for people and society, the concrete examples are far more memorable and far more impactful. So if we can learn to think about those, how we remember things and communicate those, what information is sticky, to use the terminology that's often used in the field, that's really helpful concept to get across, as are stories. So if you think about what we remember, we as humans are primed to remember stories. They stick with us, whereas abstract examples and concepts do not. And there's loads of examples of that which you can find in the literature, and be happy to signpost in further reading actually after this webinar. And again, this is coming back to something that Sadia said really nicely, that the stories are memorable, abstract concepts are less so, far less so. And I think one other thing that I've learned is don't underestimate how quickly news travels amongst your target groups. So if you're plugged into a PPIE network and you do a piece of research, that can be cascaded and disseminated far more quickly than you can do with your Twitter feed. But for most of us, at least, there are exceptions to that, of course, but I am not one of them, I hasten to add. Challenges of PPIE, well, it's a smaller list, but I have to come up with some, because it's not without challenges. I think one thing is identifying individuals or groups to work with, and happily that's being addressed now collectively, I feel, as researchers. So many research institutes, us at universities, have dedicated PPIE officers who are there to help, and they really are incredibly helpful, I would say. Consider contacting people working with underrepresented groups. So we heard very nicely from Sadia in the previous talk about that. And obviously for many of us, that's an important endeavour. And I think, as a researcher, be prepared that not everyone will say yes. And although you might find that initially a little dispiriting, oh, they don't want to work with me, sob. It's absolutely fine, of course. We get cold calls, don't we, asking us to participate in surveys or do something or other. And I always say no. So why would I expect any different if I ask someone who's under no obligation to help with PPIE? Why would I expect them to say yes? Of course. Time and money, it does take time. There's no doubt about that. As Sadia said, if you're going to make it easier for people to help you, doing 2 sessions rather than just 1 session is going to make it easier for people. Remember, others are working. It's not just you, and they don't have flexible schedules always like we do. But the benefits more than compensate for that. So it's more than offset by the benefits, I would say. And money is an issue. For instance, if you need to, well, we all need to remunerate people for their time, and in cases of workshops, face-to-face workshops, for their travel. So it does cost a little bit of money. But that tends to be available from institutes, and also from grant funders, including, I think, a scheme that Amy might want to talk about afterwards. Grants will include funding for PPIE, and it shouldn't be cut. I liked your comment, Sadia, on being the first bit to get cut. Well, it shouldn't be. It really shouldn't be. And I think that there's more of a push to recognising its importance, and actually the funding agencies will specifically ring fence funding for PPIE now, which is a real positive, I think. And learning to communicate with a non-scientific audience, well, this is something that is a challenge, but it's one that we have to address. So it's not like there's a lack of educational material available for us as researchers. It's all out there. You just need to have the motivation to go and find it and use it and learn from it. And I think one of the things that I've learned, and again, this is personal experience, so happy to debate this, is we need to unlearn a bit of what we know. So think about all those concepts that we become so embedded within and so familiar with that we just use them in our general parlance with our peers, but actually mean nothing to the non-specialists. So in cancer, we talk about progression of disease. Well, progression in general ergot means something good, isn't it? Something's progressing. It's a positive, whereas progression of cancer is exactly the opposite. So progression of cancer means growth of cancer. So it's a term that we use in cancer medicine, but it would mean something completely different. What does it mean if a test is positive? if it's a test for HIV is positive, that's not a good thing, is it? Whereas the association of positive generally is a good thing, of course. So that's really important to step back and realise and reflect on and adjust your communication accordingly. And just a bit glib, but simple concepts to your friends. So we all remember things that are simple, of course, things that are complex, we do not. And jargon is your enemy. So again, acronyms, not good. One example that I've learned recently is using mutation in the context of germline genetics is really pejorative. So people do not like that at all. Being called a mutant is not a very nice thing to have an expert, inverted commas, refer to you as. So, you know, I didn't know that, and now I do, and that has made me a better scientist and communicator, in very simple terms. And so just to finish off with just a couple of slides about a concrete example of this from our work. So as I mentioned, I lead this LynchVax project. It's a University of Oxford Cancer initiative to develop, we hope in the fullness of time, a vaccine to prevent cancer in people with Lynch syndrome. So people with Lynch syndrome have a germline fault in a mismatch repair gene. Didn't say mutation, hasten to add. In a mismatch repair gene, which means they're at vastly increased risk of cancers, particularly cancers of the bowel and womb. And now risk might be up to 80% for some individuals. And because of the loss of mismatch repair, it raises potential vaccine targets that we are exploring with view to using that, developing that as a preventative in the fullness of time. And we've been lucky enough to have PPIE from the inception of this project. So we have 4 Lynch syndrome carriers who we meet quarterly to discuss the research and grants that we're going to go for. They've collaborated on grants, so they've reviewed the grant and helped write a lay summary, actually, which, as Sadia said, can be really, really helpful. Identify where we might want to focus our energies. And also, as part of this, we're planning a focus group on vaccination, including people with incorporating people with Lynch syndrome, because we know that vaccination probably the greatest benefit to human health in medicine throughout history, actually, but a very polarizing subject with a lot of dissenting views, of course. And I also presented this work at the Lynch syndrome annual meeting. So that's people with Lynch syndrome. They meet every year as part of the Lynch syndrome UK annual meeting. And I presented that in March 2024, which really was helpful in thinking about what was important in the project and what we need to convey. So funding and engagement. So the PPIE, absolutely no doubt, helped us secure funding for the project, explicitly commended by the committee as a strength of our application. And it was actually incredibly important in responding to reviewer comments. So we had a particular comment about prioritising certain genes associated with Lynch syndrome, which actually aren't the main drivers of Lynch syndrome associated endometrial womb cancer. And so we were able to pretty confidently rebut that with the very helpful comments of one of our PPI committee who actually has endometrial cancer caused by one of these rarer genes. So the engagement at Lynch syndrome event helped us crystallise the project aims. You know, what is it we're seeking to do? How do we want to get that across to people, to understand the needs of our target population? So there's nothing better than meeting the people that you're seeking to help and discussing things over coffee. What are their concerns? What are their hopes? And in terms of motivating our work, you know, it's motivation for your work. This kind of exercise. The motivation it gives you as a researcher cannot be overstated. It's absolutely impossible to overstate that. So just some work we've done in terms of prioritisation and publicity. So we did a workshop on vaccination for cancer more generally. This isn't specific to Lynch syndrome here, but these are some of the first thoughts about people associated with cancer vaccines here, which you know, is really quite powerful. Even just glancing at that, think about what you might want to address going forward as you do this work. And also, we were lucky enough to get some press attention for our Cancer Research UK funding, and really we were able to disseminate that and cascade that across the network of Lynch syndrome carriers through Lynch syndrome UK via our PPI network very, very quickly, which has been really helpful actually, and it's led to a lot of discussion and some really positive comments, including I mentioned motivation for your work, and I've never seen anything quite as motivating in terms of my science as this quote we had on the back of that the BBC press release, actually, that we have permission to use and share with you, and I'm sure you find it just as powerful as I do. So to sum up, PPIE will improve your research. Making time to do it properly is extremely worthwhile. Can't overstate that, actually. PPIE officers in university are happy to help. There are others who are happy to help and motivated to help. There are lots of resources available, and encourage you to make use of them. And also, don't be shy. Talk to people. Most people, the worst that people can do is say no, actually. So I think that's a real take home that I've learned, of course. So more people that I need to acknowledge than I can on a single slide, but just a few people to highlight: our amazing LynchFacts collaborators, our team, PPIE team, dedicated team here in Oxford, are absolutely brilliant, hosting the workshops and more besides, and too many others to name on one slide, of course. And that's me done. I hope that's of interest. Happy to debate things and very happy to take any questions. Thank you everyone for your attention.
That was a fantastic presentation. I think it's given us a lot of food for thought. Rihanna, you have a question for David. Go ahead.
Hi, David. Thank you. That was really interesting. I'm interested in your opinion and the others on the webinar about involving people with lived experience versus just members of the public. Because I noticed your LynchFacts project, all 4 PPIE members were members with the syndrome. Obviously, I understand that lived experience brings something very unique, but some people may have a treatment burden or a disease burden associated with having the disease that's being investigated. What are your thoughts on involving just members of the public?
Yeah, it's a great question, actually. I suppose for the specific example of Lynch syndrome, because it is such a big part of people's lives, from talking to people with the condition, because most people with Lynch syndrome are diagnosed after they have a cancer. So they don't know they have it, and then they're diagnosed with a cancer because we're not very good at picking it up. And then the testing reveals that they have the characteristic features of Lynch syndrome in their cancer, and then follow-up testing reveals they have a germline mutation, mutation, correct myself, germline variant and mismatch repair gene. That experience, that lived experience, is incredibly valuable, and also for the people that have been diagnosed because relatives have been diagnosed and then they've had testing without having had a cancer. They have all the issues about, for instance, women with Lynch syndrome, the risk of endometrial cancer, womb cancer, issues of fertility, and where you go for risk-reducing surgery. When do you have children? All of these things are incredibly difficult for people with Lynch. And I think that, this is just my opinion, but I think that the general publishers, the lay public, would not have any insight into that, actually, which would be helpful. So it would be helpful broadly in terms of vaccination, yes, but for this specific indication, I'm not sure that it would add value. But I'd be happy to consider others' viewpoints. Others may disagree, of course.
Thank you.
Do we have any other questions for David? I'm just looking down the list while people are thinking. I had a question. I was really interested in, you mentioned pilot grants, David, for getting PPIE up and running, especially when you're looking at that research setting stage, so before you've got a grant, so it's kind of seen as unfunded. Do you think pilot grants are widely available enough? Are they hard to get? Are they accessible to early career researchers as much as senior researchers?
Yeah, I can only speak from my experience, which is localized, really. So in Oxford, we've got a real push for this, actually, which I think is helping. So we encourage our early career researchers to go for this kind of thing. Obviously there are schemes that you're aware of, but I think that I don't know. I'd be interested to learn from others about their experience in their institutes, whether they feel that there are opportunities. It would be a great thing to sample, actually, because if it's not quite the same everywhere, if there are gaps in some institutes where it's not being prioritised as much as it should, we should really work collectively to address that, shouldn't we, I think?
And possibly our speaker at the end of the webinar might mention something about that, because she works within the university system supporting PPIE.
Yeah, great point, actually. Yeah, look forward to that.
I know Louise has put something in the chat, just commenting on Rihanna's question about public participants versus people with lived experience. Let me just have a look at her whole chat. So she's saying, sort of echoing what you're saying, David, depends very much on the topic.
Yeah, strongly agree, Louise. Yeah, sorry, Amy.
No, don't worry. Sadia, go ahead with your question.
It was just a comment, actually, regarding the pilot grants. Some of the work that we were involved in, it was harder for researchers to apply for their university funding. You know, it was much difficult process than to apply for an NIHR grant, for example. So there are things out there, but the understanding I got was that it was really hard and difficult to apply for. And then another comment on, you were saying about communicating your science to a lay audience, and it's the what and the why you're doing the research. But I think it's also important to, like you were saying about stories, and I was also saying about stories, the stories behind the science, or the stories behind the researcher, or the stories behind the scientist. Why? Yeah. And I think it's people connect on those human factors. So on those human identities, you know, who are you? Why are you doing this? Who is funding you, for example? You know, there's a lot of lack of trust people have with scientists. So that information, I think, really helps to build that trust and build those relationships. For example, one of the we did, you know, when I was helping to recruit, we said there's a group of mothers that work at the university. We didn't say they're academics or researchers. There's a group of moms that work at the university, and we're conducting this research. So you know, relating to the identity that people can, you know, recognize rather than, and not fearful of, rather than like an academic or a scientist.
I think yeah, that's an exceptionally useful insight, actually, isn't it? The faceless scientists is it is a perception, isn't it? But scientists are human as well. They've got a story to tell. Yeah, really good. Yeah.
How comfortable they are actually with sharing that story. You know, I think we have to be careful of expecting too much from researchers and academics. You know, you don't need to share your life story. And also, we were talking about PPIE and, you know, holding different sessions, but then researchers need to balance their working time as well. There's, you know, that Athena Swan, for example, you know, you're in, you know, your working hours, and then, you know, you're out of office hours, and not expecting too much from researchers. So it's I think it's a balance, and it's a difficult balance to kind of get to.
Thanks, Sadia. That's actually a kind of a perfect intro to our next speaker, Louise. But before we move on to Louise, I'm sorry, Tony, I think we're going to take a 5-minute comfort break, and then we'll move on to our next speaker, just in the interest of time. But Tony, if you want to put your comment or question into the chat, then do that, and we can follow up that way. So let's reconvene at let's say 8 minutes past, if that's okay, and we'll start with Louise's talk then. Thanks, everybody.
Thanks.
Okay.
Amy, sorry, Amy, I have to drop off, but thank you very much.
Well, thank you so much, David, for today. That was really thought-provoking. Thanks.
Thanks. Sorry to miss your presentation, Louise.
Oh, that's all right. There's a paper.
We'll send it to you. So we're going to move on to Professor Louise Locock from Aberdeen, who's going to talk about the view from researchers' side and PPIE. Over to you, Louise.
Thank you. Yeah, maybe a slightly more controversial approach. I should just acknowledge that this was work done when I was at Oxford, and it was funded by the Oxford Biomedical Research Centre. And there is a paper, as I was just saying, which we can share around. So this is research that we conducted with 36 researchers and research managers, which also included some PPI coordinators as well. We video and audio recorded the interviews, and there's a summary of our thematic analysis available online at this link, which looks like this. And there we've got, because we record on video, you can see people talking about their experiences. I'm not going to use video today because it tends to blow everything up when you try and do video as well as slide sharing. So just going back a step, assumptions about PPI. This quotation from Sally Davis, that no matter how complicated the research or how brilliant the researcher, patients and the public always offer unique, invaluable insights. Their advice invariably makes studies more effective, more credible, and often more cost efficient as well. I mean, it's great that it was promoting PPI. Does it always make research better? Is it invariable? I think that's a little bit questionable. The evidence base remains a little weak, although it's growing over the last few years. The kind of people who get involved, as Sadia has been telling us, are often disproportionately white, middle class, and often retired. And even for them, actually being effective as PPI representatives may be hard, because there's this power imbalance and a fear of kind of the great scientist and kind of being a bit overawed by the whole thing. I think two other things on impact that I'd say. One is that when PPI is done really well, it's really hard to single out in a clinical trial kind of way what difference PPI has made, because when it's done well, the PPI representatives are a functioning part of the team. And we don't ever say, what difference did the health economist make? What difference did the statistician make? They just become part of the team, and they're, you know, everybody is working together. So singling them out, I think, is a little bit problematic. The other flip side to that is when it's done badly, it becomes a self-fulfilling prophecy that people say, well, I'm not really expecting it to work. I'll just get a couple of people on a committee. Oh, see, it didn't really make much difference. And therefore, you know, there's no evidence that it works. However, what I'm going to talk about more today is this idea of the researchers being the powerful people and the PPI people being disempowered. So researchers' experiences of doing PPI, I think often they feel less powerful or less in control than we might assume. And as Sadia mentioned, that you know, time is difficult when you're a researcher. There are conflicting demands, and PPI is just one more demand. Having said that, in our research, we found lots of positive accounts, and people were generally very positive about the drive, Sally Davis quotation, for example, to push PPI and make sure that it is done and it's done well. And the NIHR led the way really on that. So some positive experiences. So here's Marion, who is a researcher in maternity. And she says, for me, there are more benefits than challenges. And this is similar to what David was saying, actually. As a clinician, you get a real buzz from having cured somebody, or you've delivered a healthy baby where it died. You get that kind of buzz every day. As a researcher, our positive reinforcement occurs over a much, much longer scale. And so I get my tiny bit of that positive reinforcement from my PPI groups. That can sustain me through the year, raises my enthusiasm to battle the challenges of getting research funding. And here's David, who is a clinical trialist in orthopedics. And he talked about how he was a convert. So in the early trials, we tended to have what I would call tokenism for PPI. We felt we knew best and set the research questions as an afterthought, more or less, thought we better have a patient almost rubber stamp it. And that involved picking a friendly patient who perhaps one of the clinicians or myself had seen, bringing them in to sit in a committee meeting, probably without the expectation of a great deal of involvement. It was ever so slightly patronizing, I suspect, and it didn't embrace what we now know as proper PPI. As academics and clinicians, we tend to think we know what's important to patients, and that's often not the case. It makes me realize that what we think we know, we don't, and the patients often tell us something entirely different. So that was some positive views. There was a little bit of ambivalence expressed, and this is Alison, who her quotation has made it into the title of the paper. We asked a question because we were using a particular framework, which I'll come back to in a minute. One of the questions that is suggested by this framework is, how much do you want to do it? And it gave some really fascinating answers. So this was Alison quantifying it with about 60%, I want to do it. But the public message we have to sort of endorse and support is it's terribly valuable and important and makes a massive difference. So I think that sort of disjunction between what I think inside and the kind of public story I feel uncomfortable with. and occasionally some outright hostility. And I should say that this person is actually somebody who does a lot of PPI and does it really well. But she's kind of echoing Alison, the fear of not being able to critique it and saying it's a complete nightmare because I've got to be really careful as to what I say and do. PPI is really trendy at the minute, and I'm not saying it hasn't got a place, but it's like, oh, brave new world. Patients should be like co-applicants on bids. Actually, I do agree with that in some respects, but patients should be co-applicants. Patients should be researchers. Why don't we just effing bring a load of patients to come and sit around my desk? Why did I bother doing a PhD? Do you know what I mean? And she didn't say effing, but the NIHR don't allow you to use swear words when you're presenting findings. So it's like really difficult because these people are quite capable, but they've not had the training. They've not worked as a researcher. Everyone knows that to be a researcher, you've got to cut your teeth, you've got to do at least 3 degrees, you've got to do an undergraduate, master's, PhD. They just want to bring in these people who've got nothing to do with anything and let them loose on our study. I personally don't agree with that view, but I think it's really important that we understand that that is how some people feel, and they may not feel it all the time. Maybe they feel it some days, and it just affects how they behave that particular day. We've got to understand these reactions in order to be able to address them, rather than just, it's all sweetness and light, everything is fine. So the negatives. People talked about how they had to do it to get the money. As Anne was saying, it's politically correct, unable to express disagreement, fears about being attacked, feeling that it's insulting and unfair, and concerns about how to channel difficult people with an agenda or an axe to grind. One of my colleagues used to have a slide which said, striving to grind our axes in acceptable ways, and dealing with their own and patients' emotions. So I mentioned we used a particular framework. What we used is the theoretical domains framework. If you're not familiar with it, it's a work by Susan Mickey where they analyzed all the different psychological frameworks that people were using to try and understand why people do or don't adopt evidence-based practices. And they came up with these categories that you need to think about when you're looking at trying to evaluate the implementation of evidence-based medicine. So we applied it to taking up this new practice, PPI, and I'm going to talk particularly about the ones in red as they were amongst the most relevant for us. So on the social and professional identity, people are much more likely to adopt a practice or an intervention that they think is consistent with their professional identity. For some, that seemed entirely consistent with what they do every day, particularly clinicians and talking about patient care, like Marion was saying. But at the same time, there was also some concern that it was inconsistent with their professional identity. People talked about career suicide, not a fortunate term really, but that's what people said. That, you know, doing too much PPI was seen as, you know, really not making you a good researcher. Conflicting priorities, publishing and grants being the kind of the driving force behind academic careers, and it being seen as a junior and often female role. So gender did come up quite a bit. Here, Kerry says, I find it interesting that so much of the researchers who are involved are female. Is that because the sorts of skills are often softer skills about communication, listening, and empathy? Or is it because it's not actually seen as a core thing and it ends up getting sidelined? If there's more money and it's seen as having more profile, will that bring more men in? So it's very good that we had David today. I'm feeling that it's undervalued. So I wonder sometimes if that's why they give it to kind of the younger researchers, because it's like, oh, basically, you're a nice young girl, aren't you? You're inoffensive and you're nice to people, so you can go and do the PPI. It's almost like the kind of the principal investigators saying essentially it's some kind of coffee morning. I wouldn't say formally that there's a gender issue, but I think it hints at the lack of values that's being put on it. I personally would always like to see people who've got a bit more responsibility and authority for studies actually going to these meetings. And certainly I've been in projects where the PI has been very committed and has attended PPI meetings, and some where they haven't. On the beliefs about consequences, Andy's comment here, I think, echoes what David was saying about the concrete examples. There's nothing beats actually seeing it happen, seeing it work, and seeing the contribution it can make. We can all tell stories about what PPI is meant to do, but I think there's nothing like actually delivering it in practice. I've never seen it to be my role to just go around and say, well, you should be doing PPI, don't give me any excuses. On the other hand, Marion, a strong advocate for PPI, just reflecting that it's a difficult tightroad to walk, because politically you can't say, I think this is rubbish, or I don't believe that. And hypercritical Anne again, PPI is held up as this thing, as a shining beacon we must aspire to. It's essentially seen as 100% positive. There's nothing bad about it. You know, that's what it's seen as. And it's like, why are we not critiquing the bad things about it? And here we've got a comparison between two different units with the same person. So she says, within my previous unit, everyone was pretty positive. We did have a couple of people who I think questioned it with whether it was effective or worth doing. But on the whole, everybody without fail acknowledged that it was the right thing to do, whether or not it was being effective. And of course, that's the moral case for doing PPI, regardless of whether we can prove in some way that it makes a difference. We should be doing it. But in her new unit, she says nobody seems to really even consider PPI here. Don't underestimate how tricky it can be when a more senior person has more negative, not negative necessarily, but has more set views on what PPI can and can't do. If someone in a more senior position isn't willing to open their mind and be receptive to genuine change, then there's kind of no point in you trying, really. So here's that social influence shifting from one unit to another. In the first, encouraged to do it and think about it. In the second, kind of discouraged. And just a little bit more on that, Bernadette, the senior people think it's a waste of time and a box ticking exercise. And a lot of what I've been doing, I've been keeping it quiet because I don't want to tell anyone to tell me that I'm wasting my time. Amy saying, I remember one A&E consultant who was very dismissive of the patient perspective. So for me, it brought us back to what we should be doing. For him, it was like, will you please, shut that lady up? He was really dismissive. So which only made me all the more determined to involve people in the future. So sometimes the social influence can have an unintended consequence. I do think the culture of the organization is an important support for being able to do this properly and feeling it would be much more difficult if you were on your own doing this without a supportive community of people. Turning to the emotions, there was a lot of positive emotion words, so buzz, empathy, inspiring, uplifting, but also some fear, distress, and anger. And Suzanne here saying some people probably, I'll probably include me in this, might find that a bit threatening sometimes. And I think it's down to your own confidence, lack of confidence, and lack of experience probably of doing it. So a little bit of nervousness around getting into PPI. And Marion made the point, because she works on neonatal deaths and maternity emergencies, so I worry about some of my junior researchers. So, I've had my family, and other of my researchers haven't. And I do worry about them being exposed to their contact with PPI. They're not medically qualified, they're only contact with childbirth experiences, this very extreme negative side of it. So really quite distressing for some of the younger researchers. Of course, it's also very distressing for the PPI representatives, and that kind of double emotional whammy can be quite difficult to deal with. There were several people who were kind of a bit upset about the way that researchers are portrayed in the PPI discourse. So I don't like this idea that researchers are bad and people who are involved are good. I don't feel like this nasty researcher that's sort of making all the decisions. PPI partners were saying researchers are this and researchers are that, they can't talk to real people. And I got really upset by the end of it. So I went, I am a real person. And Sarah saying this idea that we need PPI because actually we're all these kind of, robotic, unfeeling people who don't understand what patients go through. I've spoken to hundreds of patients. I spend all my time exploring the impact on them. And you're telling me that I don't know anything about it. It's almost a bit of a professional insult and a bit of a personal insult. And again, this is somebody who does a lot of PPI and does it very well. So just to finish, some issues around power. So we tend to assume in debates about PPI that researchers have the power and PPI representatives don't. But I think that neglects how hierarchical academic life can be, with the very senior people right down to the junior researchers and the PPI coordinators who may feel pretty powerless. And power is unevenly distributed in academia amongst researchers, between research disciplines, between researchers themselves and the organizations and processes which shape their lives. So what their university employers tell them to do, what the funding bodies tell them to do, what ethics committees tell them to do, and peer review. So I would just conclude by saying, I think some researchers are more dependent and lacking control than others, and we need to factor that into thinking, how can we help everybody do it better? So just some thanks to people who worked on the study with me, and the usual funding acknowledgement. Thank you. I'll stop sharing now.
Thanks so much, Louise. That was extremely thought-provoking. I think a lot of issues brought to the fore there that we maybe don't consider or shine a light on very often in this discussion. So really very helpful start to lots of discussions, I think. Let's start with Rihanna. You have a question.
Wow. I suppose it's made me realise how insulated I am within our trials unit, because as far as I'm aware, we don't have investigators that have those opinions, and that's really interesting to know that those opinions are out there. And actually, I have experienced where I've been asked to be the friendly face talking to the patients because I'm less intimidating than a researcher might be. And you've made me think, is that because I'm a nice young lady, perhaps? Yeah, very thought-provoking. And I think maybe there are researchers out there who need to know that some other researchers feel this way and they're not alone. So yeah, I'll definitely be having a look at that research in more detail and perhaps sharing it at our trials unit. Yeah,
I think things have improved over the last 10 years or so. I think attitudes are shifting, but there are still people out there. And there was one person in particular that we were trying to interview because we knew he had really negative views. And in the end, he declined to be interviewed. So I'm kind of, we probably only scratched the surface of some of these negative views, really.
Yeah, because as you said, it's a stigma, isn't there? And it's not politically correct. So people are going to be reluctant to come out. Was there the option for them to be anonymous?
Yes. So Anne is not her real name, and she's written only. There's no audio or video from her.
But very important to have that view represented.
Yeah.
And I think what's nice is that the feeling seemed to be that everybody agreed with doing it in some way. It was this feeling that it's become the most important thing, and that researchers are bad or wrong if they're not immersing themselves in PPIE. I think that's something for us to be really mindful of. Yeah, fantastic. Thank you.
Thanks, Rihanna. Does anyone else have a question I'd like to put to Louise?
Or a counterblast.
Or a counterblast. I have a question while I'm thinking. Some of these issues feel intractable. It feels like, we're talking about culture change in a sense. Do you think there are any low-hanging fruit in terms of what different organizations might do to help the researchers who struggle with getting into PPIE?
So I think probably the two things, I think principal investigators need to role model better than they do sometimes. That means giving it the importance that it needs, attending the meetings, valuing people's time in taking part in it. I think the other thing that really helps is having a dedicated PPI officer, even if they're only part-time, because it just takes some of the administrative burden off individual early career researchers who are struggling to kind of complete the research and then also being expected to, book the teas and send out invitations and things, and even the finding of people, because a good PPI coordinator is worth their weight in gold in terms of keeping a really strong network of people going and encouraging them to take part in different projects.
Thanks. That's very, very helpful, and some real sort of tangible ideas for us to think about. Rick, were you putting your physical hand up there?
Yeah, I can't find
What
that
you had
hand
the
button, which is ridiculous. I'm always running these things, never to ask questions. Thank Louise, it was fascinating, really, really interesting to hear about the study, and I thought you presented it brilliantly. Really good to hear the very different perspectives that are present there. I was just thinking about what you were talking about. I wondered, how much do you think some of the negative views and connotations are probably a consequence of people feeling that the PPIE work is being imposed upon them rather than a choice to move towards doing it, and how much is actually a response to having less positive or negative experiences about the delivery of the work itself?
Yeah, I think some of it is a response to feeling it's been imposed, but the feeling that it's being imposed can be alleviated if your PI is really positive about it. And at the same time, I think a lot of people felt that, you know, yeah, they might have their own reluctances, fears, anxieties about it, but they knew that the push to do it was a good thing. So there was kind of pretty much universal positive comments about the NIHR's drive to do this. It's not that people don't think it should be done. I think a lot of it is more about how it's done, and the kind of trepidation if you've never done it before. So trying to support people who are experiencing that trepidation, I think, is a key thing.
And one of our attendees has commented on the NHR requirement in funding applications for PPIE, which maybe has done a lot in terms of changing the frequency of PPIE, but maybe that's where some of the feeling of it being
it really shifted the culture, and of course culture change is uncomfortable for people. So they've been kind of maybe dragged along faster than they wanted to be, but they don't think that that's necessarily wrong. Yeah, interesting. Okay, Sadia, you have a question.
Yeah, I was just wondering, because of this, like, do you think there's a growing amount of negativity around PPI, or it just makes me worry sometimes? It's just that PPI can become a business, and people want to cut corners, and people will outsource PPIE, and then it makes you think about the value and you know, and the value of PPIE. Is there a risk of it becoming a business?
I think there is a risk of it becoming, people talk about the PPIE industry, and it becoming, you know, sort of, maybe it's one of those kind of curves where it was started very tokenistic, became much more engaged and real, and then gradually, as it's become more kind of codified and protocolized, it's become less real again. I don't know that hostility is increasing. I think probably I've observed generally people becoming more positive and more excited about it, actually. But yeah, there is still that risk that it gets too tick boxy, and the more kind of, you know, tick box requirements on the form where you have to answer 6 questions about PPI rather than just putting some general text, there is a bit of a risk of that.
Yeah, it just worries me about cutting corners, because I remember when I started my PhD and I was with all the researchers doing a qualitative research methods module, and the first thing that was drummed into you was PPIE is so important. It was like everyone was scared straight away. That's the first thing they do.
Yeah, because you forget that, you know, many of these researchers, I'm 63, but some of these people are very young and still right at the outset of their academic career, and suddenly they're being asked to do something that is quite a specialized task, which requires a lot of emotional maturity, and they're kind of being dumped in it.
Yeah, thank you.
Thanks for that question, Sadia. Really interesting angle. We are going to move on in the interest of time, and we're going to move on to Amanda. from Cambridge, who's going to give us her perspective as someone who supports academics in PPIE in her work. Thanks, Amanda.
And just thanks to all of the earlier speakers for really interesting, nuanced conversations. I think all of them I could have happily come back to, and just this last one, definitely I hear a lot of similar, or not necessarily a lot, but certainly not never get the same kind of feedback from researchers. And I think sometimes it's also about the tone that researchers are discussed in terms of their approach to PPI. And I get a lot of researchers who have done great PPI, who feel like they've done a great PPI, great amount of PPI, and get feedback from public members or reviewers saying, oh, this looks tick boxy or it looks tokenistic. And they just sort of think, well, what more can I do? Why hasn't this come across better? So I see it quite a lot. Okay, so as ever, lots of windows. Hopefully, is that slides to everyone?
Yeah, that's great, Amanda.
Lovely. Okay, so the last section hopefully will actually just really nicely summarize quite a lot of points that have been more than adequately made by all of the speakers ahead of me. So hopefully this kind of neatly summarizes what you're all thinking and hearing anyway. And this session is very much around how we can plan for hearing from a diversity of voices of people with different lived experiences, and then also how we can support people as they are getting involved in our research. And it sounds cliche, and I definitely didn't come up with this phrasing myself, but kind of the whole punchline to my entire session is just that good PPI, like good research, should start with people. Kind of typically, researchers can come at this kind of from the other direction. And again, I think sometimes this is because of the way that funding applications are structured, but most projects and protocols kind of start with the structure, and then they try and fit participants into it, whether that's a PPI plan, and I'll have a researcher say, right, I'm going to do a focus group. Can you help me find a diverse group of people to come to my focus group? Or I'm going to run a clinical trial. Can you find me diverse participants for my clinical trial? Whereas actually it's much more effective, efficient and inclusive to work from the opposite direction and start to think about, okay, so if I really want to have diverse participants, if I really want to have diverse people involved in my research, how can I design my PPI strategy, my clinical trial, my research study around the needs of the people that I want to involve? And thinking about what it means to be diverse in the first place, obviously talking about people with a range of lived experiences, a range of background characteristics, and often when I ask researchers this question, I pose the sort of the question to them. I say, well, you know, the whole point of diversity is hundreds of different types of people and backgrounds and experiences and things that I could work with. Where do I start? How do I go about involving everybody? And the key question I ask them to do, or the kind of the homework, as it were, that I set for them, is to have a look at whether or not there are groups or communities that are underserved or experiencing worse outcomes in whatever their condition of interest is. And that is a good place to start for their inclusion work, to make sure that they're able to include as many people as they need. And then looking into the needs, preferences and barriers to participation and involvement for those particular groups. And then thinking at that point, so given what I know about who it is that I'm trying to involve and what their needs, preferences and barriers are, how can I design this project with those people in mind? And I've quite deliberately used the plural here because there's never just one group. I mean, you can't have a diverse one group of anything. So sometimes that does mean needs plural. There will be different people with different needs and preferences that need to be accommodated in order for them to be included into your work. So thinking about who your key communities are, and I have an asterisk here because by community, I just mean any group of people. That might be a social community, it might be an ethnic community, a cultural community, or just a group of people who have something in common but don't necessarily directly interact with one another. But in terms of how you can know who is underserved, and again, very common question I get from my research is, how do I know who needs to be involved in my research? The answer is that there is actually a lot of data. There's a lot of resources that you can find, that you can make use of, and you should have a good knowledge of who is affected by health inequalities in your area. So there's literature available on this. Your local authority should hold data about people in your area, and similarly with integrated care boards, for example, you might have trial data from earlier studies that you've done about who was involved, who were participants, who was in your PPI groups earlier. NHS has lots of data on health inequalities. And you can also use materials like census data. But you should also speak to patient groups and charities. Many groups and charities know who it is that kind of they're working with and supporting, and they often have a good idea of both what barriers are to getting involved in research, but also they often know who they're not yet finding and approaching, and that can also give you some keys about where you need to go kind of looking, as it were, for people. And then actually, I think this point was made really well by Sadia in her discussion, that the best way to find the barriers, needs and preferences of individual groups is to ask them directly. Different people from different backgrounds have different needs, wants, desires, and ways that research will be easier for them. For some people, working with people who look a lot more like them feels more comfortable. For other people, talking in front of people that they might know, or that might know them, or might know their friends and relatives and therefore be talking about them, is actually worse than this idea of working with other people. But again, that will be completely different for other people. And so being able to ask is an obvious first step that actually sometimes I think we overlook. And obviously having the patient public involvement and community involvement in research design is absolutely crucial. And again, this point has been really well made, that the whole point of doing it this way is to make sure that we have people with lived experience and a variety of lived experience as part of the research team themselves, so that it's not just doctors and scientists and academics and administrators who are doing research, but that we're also getting that extra expertise that we need. And as we would hope then, inclusive patient and public involvement leads to inclusive research in the first place. You can't have inclusive research studies without having, first of all, inclusive research involvement, and you won't get a diversity of participants or of people who are involved in your research unless you're really focusing on the individual needs of the people that you're trying to include. And the earlier that you start this process, the better. So thinking about kind of the three main phases of research in the design stage, the delivery phase, and the dissemination phase, focusing on inclusion throughout that will ensure that you get that diversity of lived experience. So the design stage, to some extent, is a little bit easier because that's when there's more that can be changed, there's more that can be acted upon and influenced. So as the point was made earlier, really starting with that prioritization setting, with defining what the research question is. And again, different people will have different needs and preferences about what they want to see researched. And then keeping on going in the delivery phase, I think particularly in some of conditions where we are not having necessarily a diversity of participants, being able to work with recruitment ambassadors, community champions, research champions, being able to go out into their communities, talk about particular research projects, talk about involvement opportunities, is often the strongest. I don't want to describe humans as tools, but it's often the best lever that we have for people feeling comfortable or even just thinking about taking part in research. And again, I was really struck by Sadia's comment in the first talk about sometimes having relationships needing to be built over years or 18 months even before people really start to feel trust and comfortable to be able to take part in research. And then also in that dissemination phase, so much of research gets dropped off before we actually start telling people about the impact that it's actually had. And this is an absolutely essential part where diversity is key, because different people, different communities, different organizations have different media. They use different techniques in order to be able to reach their kind of groups, as it were. And so really making sure that we're asking people where they get their information, where they go looking for research results, will make sure that we're actually reaching the diversity of people that we're trying to involve and include in research. Now, I always have this slide because it is really important to think about the specific barriers of research. I'm not going to read through them all because that would be really boring and we don't have time, but they are there, they are fairly well documented, they are possible to find in the literature. And again, they are going to be different for different groups. And it's really, really important that you go through, that you understand, and actually also that you discuss specifically with the communities that you're involving how you can overcome those particular barriers for those particular communities, because much like everything else, the solutions, the resolutions, the interventions will be different for different groups with different needs of people, whether that's related to the health conditions that they have or whether it's related to some other aspect of their background. And I suppose that kind of the other main take-home message from my talk is that this kind of inclusive involvement doesn't necessarily happen by itself. It has to be something that you actively think about, in the sense that if we go about doing research like we always have, we will get the people that we've always had in research. This is an active intervention that you make in your own research to really think actively about who you're trying to involve, what their needs are, and therefore how you can involve them in research activities that are appropriate to them. And that means thinking again really broadly about what it means to be diverse, so all sorts of different background characteristics and which ones are relevant to your research. Also then tailoring and diversifying that recruitment, looking in different places, using different modes, using tailored approaches and techniques. And then making sure that we're not just having one type of activity, whether it's a focus group or an interview or a survey. None of those activities in and of themselves are in any way wrong, but none of them are going to suit every single individual either. So really being able to offer a range of different activities for people to get involved, including ones that are exceptionally informal, just having a chat, relationships that get built up over a long period of time. It's also really helpful, particularly if you are in a bit of a hurry. You know, unfortunately, I do meet researchers often who have grants that are due soon. If you can work with existing community groups where people already feel comfortable and where there's a relationship that's already been made, that can be a way of slightly speeding up the process and making sure that you go to them first. Again, a point made very well in earlier talks that having researchers be able to come to people rather than expecting them to come up to our hospitals or into our universities is a much more inclusive and effective way of involving people. And I mean, I could do a whole talk about how much time that this can take and needs, particularly to avoid tokenism, but this isn't something that can be done overnight. I think the other thing that I would like to stress that has happened a lot in the past and that I actively strive for researchers to avoid is to have a plan in place for what happens at the end of project. Don't just stop talking to people either because you've finished your research, which is hopefully a good outcome and you've published, and definitely don't just stop getting in touch with people because your funding didn't come through. Have a really clear plan in place for what will happen if you don't get your funding or once a project is finished, so that people don't just stop hearing from you. Have some kind of formal conclusion to your work. So as you start planning your activities, really thinking about laying the groundwork for your research project. So identify who it is that you think you need to work with, start building those connections with leaders, with community groups, with whoever it is that is happy to work with you. And then if you can, co-develop a realistic timeline of PPI plans and have those concrete options in place for follow-up. And also do a little bit of background understanding, whether it's through your discussions with people, whether it's through reading through the various resources that are available to understand what has happened in the past for whatever particular community group that you're working with. What kinds of perceptions do they have for research? What have their earlier experiences been? And then this process also is helpful for building an awareness of cultural and language norms and preferences. In terms of the types of activities that are inclusive, generally, if you're working with people who haven't ever been involved in research before, then informal is usually better. So a lot of researchers kind of go straight to, I'm going to have a focus group, I'm going to have a meeting, it'll have a chair, it'll have an agenda. And that's actually not a very normal way to interact as humans if you're not part of kind of the meeting sphere. So food is near universal, even just gathering for some kind of meal. It's not completely universal though. Once when I was giving this presentation, I had a person with lived experience of autism sort of say, well, that they really can't eat in front of people, in front of other people. For them, having to have a conversation over food would completely shut down their experience because they really don't feel comfortable that way. But for many people, it is an opening that people can share because it is such a commonality. Some people really like physical activities, things like dance or sport. There's a group in the Cambridge Applied Research, in the East of England Applied Research Collaboration that does town walks, where they go for a walk around the town with different groups and communities, and they talk about research while they do that. Some people like to do something with their hands whilst they talk about research. So whether that's craft activity or cooking or something like that. So again, a familiar activity with the background of talking about research. Some people find drama and storytelling helpful, but again, please ask preferences and co-create the activities. Sometimes assuming that people would love to do dance with you or would love to do drama can be just as exclusive as going straight for the meeting. And again, the best way to be inclusive is to give people choice. And I think before I move on to the next slide, finally, a lot of this is, again, really time consuming in a positive way, but in a really pragmatic, this does take time. Focus on the relationship above the results. That's what you're there to do. You're not there to mine people for information. You're there to get to know them, to understand them, and then to talk about your research. But while you do write down the things that you're hearing, because it's also very possible to have wonderful conversations. And in fact, my experience often is that you have fantastic conversations, and then you get back, you get to your inbox, you get to your grant proposal, and you think, goodness, what was it that we talked about? Again, so making sure that you have some kind of record of what you're learning. Other things, again, really simple, and I don't want to dwell on all of these, but there are some really clear things that you can do around making sure that people feel genuinely welcomed and that you're considering the types of needs and preferences that they have. And that you are offering things like training and support to them to help them build their skills and experience in an area too. And again, I can't overstate how useful it is just to simply ask. And I think this is particularly true after a first meeting. So yes, ask people before they go, but if you've never been to a PPI activity before, you might not know what it is that you need. So after that first experience, asking, is there anything I can do to make this more comfortable for you next time? Similarly, with accessibility, there's a whole range of established literature around ways that you can make people with different lived experiences feel more comfortable and make things accessible to them, whether it's quiet places or carer support or transcripts and materials. Checking that there are appropriate facilities for both children and adults is really important. And also that things like translation are accessible and that you're familiar with how they're used and how communities prefer to use them. Again, if you are inviting people and you've got kind of like a poster for your recruitment, it can be helpful to let people know you're going to do this, because many people who have accessibility requirements are so used to being excluded that if you don't reassure them that you have thought of their needs, they just won't want to come in the first place. So once you've done your PPI activities, you've done your research project, also really, really important to think about inclusive conclusions to make sure that everyone feels heard. So making sure that you thank everyone and that you update everyone who has been involved in your research. Make sure there's a plan in place so that people can hear about what the study results are and how they can expect to hear them. Making sure that there are clear arrangements for reimbursement and receiving feedback. So people hate to ask, they really don't want to have to nag and follow up and say, you know, I've got my form, when will I be getting my fairly small payment? You should be very clear and be prepared at the start. It's going to be a lot of bureaucracy on your end, and ideally you can overcome that before those forms have to go out to your contributors. And then also being clear what those next steps are for your research and whether or not there are any opportunities to be involved. And I think the other thing that's really important is to keep your door open. You've gone into a community, you've asked for some support, some feedback, and this should be a two-way process where people should feel free to approach you, whether or not it's for questions, for information, for research ideas, etc. That should be a reciprocal relationship that you have developed with the community. So the second part of my talk is thinking a little bit about where you can go for help and support. So Amy asked that I cover where you can find PPI kind of support. And I've made this fairly general, but we can have some more specific questions in the chat. So thinking about where you can go for help and support, we've actually covered a little bit of that already in this session. So the first and most obvious two places that I would suggest you go in your region are to check with your local university and your local NHS trust. So most large universities and large NHS hospitals will have a PPI team. And I flatter myself, but PPI teams are a wealth of experience. They will have ideas about where you can go. They'll often have resources that you can use. And the vast majority of us are very happy to sit down with researchers, with community organisations to discuss specific projects and give you advice and guidance on how you might get started, for example. The other place that that can be underused is funding bodies themselves often have a lot of their own guidance. So you can see all of my slides are NIHR branded because that's who pays my salary. But the NIHR does have a lot of guidance around what they hope to see for public involvement, for example, and lots of actually really good advice around inclusion, around working with underserved groups. They've just released some guidance about working with people with limited capacity for consent, for example. And then some of the other funding bodies, so this is Health Data Research UK, also has similar resources that you can use for doing research using health data, for example. And another area that also has lots of really independent advice, if you kind of want a second opinion or you want specialised advice for working with particular groups, charities and patient support groups themselves. So Genetics Alliance is a good example. Rare Disease Research UK also has some great guidance around PPI. Also groups like Cancer Research UK, and then organisations like Healthwatch are also really good sources of expertise for working with particular communities, for example. They often know a lot about what's on the ground and who is underserved in research in your particular area, etc. So a really good resource for advice working in this area. Kind of also an emerging group, if you've got funds to be able to work with them, is that there's actually organisations these days whose reason for existence, as it were, is to improve involvement and participation in research. So this is just one example, is Equality Health. Other examples are available, but they are organisations that you can pay to come onto your grant with you, who have real expertise and kind of feet on the ground, as it were, in different communities to help you recruit, particularly from communities that are routinely excluded from research. Then again, working with community organisations, many people are willing to say yes. And again, this came up in earlier talks. Sometimes you do have to make a lot of contacts to get a yes. But I think it behooves researchers to understand, you know, for those of us who, like myself, get hundreds of emails a day, that can also be true of community organisations, whether it's different contacts. Sometimes you do need to persist, but by and large, people do want to help. They want better outcomes for their communities as well. Also, your local council and public health team, again, a really great understanding of what it's like in your local community, and particularly within large cities. So if there are areas of inequality, for example, Cambridge, this is a really useful resource, certainly for us, where our city is quite diverse, even just within our city, in terms of the different outcomes that people are receiving, and actually really underused even by researchers who are just kind of not often aware of what's happening in local government. But there's a real source of expertise there that should absolutely be worked with. And again, it seems like a bit of a silly question, but the types of things I would encourage you to ask help for, that you can ask help for when you're starting to set out in your patient and public involvement, again, is around this intel. How do you get to know the communities that you're trying to work with? How do you understand who it is that you're trying to hear from? And so when you start working with, whether it's Healthwatch, whether it's your local council, whether you've identified a community leader, or even one PPI contributor who comes from the community that you're working with, some of the things that you can ask them for help with are things like, can you tell me more about your group, your community, the people that you work with? Can you suggest someone else that I might speak to next? Is there a person you could introduce me to? Do you have an idea of what my next step should be? And then also asking them, you know, if you've been approached in the past, what worked well? What didn't work so well? Is there something that was a disaster? Was there something that worked really, really well for recruitment? Also asking for help with strategy development. Obviously, that's what I spend a lot of my time doing. I meet with researchers, we talk about the project, we have a think about who might be useful to talk to. And again, a lot of time this comes back to activities and approaches that might work for particular people. So, you know, again, as researchers that come in and they say, Amanda, I think I'm going to do a focus group and a survey, and we'll sit down and we'll think, well, yes, that will work for a lot of people. What other types of activities and approaches might we do for people who won't have time to come to a focus group, or might not enjoy it, or can't contribute to a survey, for example? And then also working with people to recruit to some of those PPI roles. So if you're building a PPI group, for example, if you want to have a co-applicant, working with your networks to find the right people for those roles is often one of the best sources of help that you can get. Finally, asking for feedback, review of your plans, deciding what kinds of how you should respond to some of the feedback. And again, I think in the talk just before mine, some of those really difficult and sort of slightly thorny pieces of responses, either from members of the public or from researchers, sometimes having support to work through some of those and decide how you're going to respond to them is an area that people need support with. Also looking for examples of researchers who have gone before you, or community activities that have worked. I have a whole library of example documents of things like lay summaries, or patient information leaflets, or PPI group kind of recruitment materials. And again, introductions to other researchers who have been in a similar field or work with similar communities. And the rest of my time I spend doing PPI training. So there is lots of PPI training available, not just through Cambridge BRC, but a lot of, I noticed a lot of my colleagues from my fellow BRCs also run quite a lot of training. Universities run quite a lot of training. Also looking at trainings that are slightly outside of the PPI field. So training in equality, diversity and inclusion, and in health inequalities has been really useful for informing my work. And again, the point has been made several times about the value of really good facilitation skills. And there's actually quite a lot of training available in those veins as well to give you the confidence that you need to run a meeting well. So my last slide, Amy, is just resources. Actually, I'll share with you because they're useful, but they're there so I didn't forget them. And I will stop sharing and just snuck in the deadline.
Thanks ever so much. It's really nice for our last talk, I think, to focus on lots of very positive and practical tips to help people get support and get started. We have a couple of questions. Pooja, let's come to you first.
Thank you. really interesting session today. Enjoyed it very much. So I am an ex-researcher, but I work for a charity now. So and I think one of the things I was missing today, although a few people touched, and especially Amanda, is the role of charities in facilitating patient-public involvement and engagement at the TSA. So tuberous sclerosis complex is a rare genetic condition. There's roughly about 11,000 people in the UK who have the condition. So we help researchers, we facilitate PPI for them. And the way we do it is we have a very, very engaged research volunteer network. So we actually have a pool of 40 people who are, who want to help researchers deliver any aspect of PPI, be it reviewing summaries or sitting on advisory boards or steering committees, reading, lay summaries. And I think there are various advantages to that. And we've actually been fed back this from the researchers as well, that having us as a charity or a patient organization as a collaborator really gives confidence to the funder that tick box at the, PPI just hasn't been a tick box exercise. It has been done properly. It also helps with, give funder the confidence that if there's patient involvement, that the retention and recruitment will be higher because the patients have input. I mean, I'm an ex-researcher. I used to write applications like, oh, we'll take blood from asthma patients 3 times a day, or without even thinking the logistics of a patient coming, how will it happen? How will it deliver? So when the methodology is being reviewed by researchers and you articulate that in your application, it really, really helps your application. So yeah, I just wanted to, highlight the role that charities play, especially condition charities. I would say involve them. We have the pulse of the community. We've got research strategies that, that have been developed with patient community. Priority setting exercises. A lot of bigger charities do James Lind Alliance exercise as well. So again, you can basically articulate that in your application as well, that we are focusing on an area of an unmet need. This area is very, very important to the patients. So there are loads of advantages of, going to a charity or working with a charity when it comes to PPI.
Absolutely, an absolutely underutilized source of expertise in and of itself, and then connections through to patients are exactly what we're looking for.
And we're lucky in the UK that we have quite a mature environment in terms of charities like Pooja's and what they do. We are slightly over time. Rihanna, we'll come to you. Would you be able to make it very brief so we can finish soon?
I'll try my best. Thank you, Amanda. That was really helpful. I'm interested if you've had much experience with rebuilding relationships with communities. There's anecdotal evidence that our institution has not done it in the best way in the past, and that there's a bit of bad feeling between communities and us, feeling like they've been used. And that's probably from not having that end of project plan that you talked about and continuing to engage with them after we've used their resource.
And I think sometimes it's about the lack of end of project plan. Sometimes I think it's also a reflection of short-term contracts in the research environment. So some of the times that yes, I've got experience in this area. It happens much more often than I wish that it did. And I think some of the work, and in fact, I have a much longer session on this where we talk very much about that, how about one of the first steps for each researcher should be giving communities the opportunity to talk about what has happened to them in the past, both kind of historically, but also more recently. But yeah, if you've got a research, we've sometimes had research fellows who are absolutely fantastic at doing community engagement. They build beautiful relationships. They do it really, really well. And then they get a postdoc in Edinburgh or Singapore or Australia and they leave. And, in the whirlwind of finishing and writing up, they, the literal entire relationship gets lost. And then because their email stops working, they can't even get in touch with communities. So I do think that is kind of the next direction where this field needs to be heading. And I think one of the answers that is being attempted for this is in the last 10 years, we've had the proliferation of roles like mine, which is a PPI lead, aimed to sort of have some continuity in this area. Increasingly, my organization has just hired into a role called the Inclusive Research Manager, and different organizations are having similar ones that are aimed to be roles that can kind of straddle some of these relationships, that can pick them up when people go, that can try and knit things together. because yes, I do worry sometimes that with all of researchers quite enthusiastically going out and saying, you're right, we haven't been doing this well in the past, let's start being inclusive, and creating all these relationships that then just get broken and lost. And then sometimes being a little bit too enthusiastically and going in a little bit heavy-handedly as well, which is also something that we can work with training.
That's great, thank you.
Thanks, Amanda. Thanks for that question, Rihanna, as well. That's a really important question, something that I hadn't really thought about before. I'm going to wrap up now really quickly because we're 5 minutes over. I do apologise to everybody. I just want to say a huge thank you to all of the speakers today for providing really thought-provoking, really interesting presentations. We will be sharing the recording of the webinar, so you can share it onwards, and we'll be putting it on the website of Rare Disease Research UK. We'll also be sending around a really short evaluation form for everybody. So if you're able to fill that in and give us your feedback, that would be extremely valuable to us. So thanks ever so much, everybody, for attending. Bye-bye for now.